Great. So Mr. Smith is a 60-something, 64-year-old heavy smoker, 40-pack year history, who's got moderately severe COPD. This was diagnosed on PFTs when he had obstruction. His symptoms are notable for dyspnea when going up 2 flights of stairs or when walking several blocks on flat ground. He's got a persistent cough. It's productive of clear sputum, and he's on LAMA monotherapy with an as-needed albuterol. His symptoms show a decline from when I saw him 6 months ago. Thankfully, he hasn't had any exacerbations needing steroids or hospitalizations in the last year, and he doesn't have any signs or symptoms of heart failure. Otherwise, his COPD care is up to date, including vaccinations, flu, and pneumonia. He had PFTs today that were stable from the last check, and a 6-minute walk test that didn't show any desaturations requiring oxygen. He had a normal echo about 1.5 years ago. So I think the differential for his worsening dyspnea includes uncontrolled COPD, deconditioning, new heart failure, or pulmonary hypertension. Some other things like diaphragmatic dysfunction, neuromuscular weakness, infection, pneumothorax don't seem to fit for his presentation. I think the most likely cause of his worsening is uncontrolled COPD, given that he has significant airflow obstruction and he was only on LAMA therapy previously. Despite his symptoms, he doesn't really describe any change in his activity level, so I don't think deconditioning is at play. He also doesn't have any signs or symptoms of volume overload, and I have that TT from 1.5 years ago. I still want to keep heart failure in mind. I wanted to hear if you agree with the differential, and in particular, if you would do any other testing at this point. I was also planning to discuss lung cancer screening with him today.
All right, great. So I agree with your differential. It sounds reasonable that this is most likely uncontrolled COPD, but I like that you thought about other things, particularly heart failure or pulmonary hypertension. But it seems a little bit less likely based on the story that you got and that you gave me. So if his dyspnea is getting a little bit worse, then I would think about getting a repeat echocardiogram, but probably the one that he had recently should suffice. And then I totally agree with getting low-dose CT scanning to look for lung cancer. And then after you have that discussion with him, if he decides to go for it, we can take some other things off of our differential. So how about you summarize what's your plan for him today?
All right, so here's what I'm thinking. For his worsening dyspnea, since I think it's uncontrolled COPD, I want to step up his therapy from the LAMA alone to a combination LAMA-LABA. And I'll check back in 3 months and see if his symptoms have improved. If he isn't better, then at that point, I'll go get the TTE looking for heart failure or pulmonary hypertension. And today, I'll talk to him about lung cancer screening. I'd like to be more confident in my overall approach to conversations about screening, so I'll make that the thing that I look up today after the visit.
Okay, sounds great. So before you start, I know that one of your big goals for these past couple months was to make sure that all your patients had the appropriate up-to-date screening. So if that works for this patient, let's make that a focus of today's discussion.
Perfect. I think it will, actually. So Mr. Smith is a 64-year-old man. He's a former heavy smoker. He has a 40-pack year history. And he was diagnosed with moderately severe COPD on PFTs a while back. His current symptoms include dyspnea when he walks up 2 flights of stairs or if he walks for several blocks on flat ground. He's got a persistent cough that's notable for clear sputum production. He's currently on LAMA monotherapy with an as-needed SABA. His symptoms show a decline from the last time I saw him 6 months ago, but thankfully he hasn't required steroids or hospitalizations in the last year. He also doesn't have any signs or symptoms of heart failure. And otherwise, his COPD care is up to date. He's had his vaccinations, flu and pneumonia. He's got PFTs that were repeated today and show that they haven't worsened since the last visit. And a 6-minute walk test that shows that he doesn't desaturate when he ambulates. He had a normal echo about 1.5 years ago. So I think his new dyspnea is mostly just his progression of his COPD. So I want to increase his inhaler from just a LAMA to a LAMA-LABA combination. If he doesn't get better, I'd probably go for a TTE to look for heart failure or pulmonary hypertension. But at the moment, he doesn't have any signs saying that I should do that today. In terms of screening, the thing that I'm leaning towards is lung cancer screening. He's already up to date on his vaccinations.
Okay, great. Your plan for his dyspnea sounds very reasonable, and I agree with increasing his inhaler regimen and then getting a TTE if he doesn't seem to get better after a bit of time. Tell me why you're thinking for lung cancer screening for him.
So he, with his 40-pack year history, and because he quit less than 5 years ago, I think he meets the necessary criteria. And he doesn't have any other life-limiting diagnoses, so I'd recommend a low-dose CT for him today.
Okay, so let's focus on the shared conversation you're going to have with the patient when we go in the room. So I typically use the CDC lung cancer screening guide, so that's going to give us a helpful infographic that really helps make sense of this for the patient, talking about the risks and the benefits, and also having a questionnaire to really try and understand the patient's preferences in this decision. It sounds like you're already well versed in the criteria for screening, so instead really let's focus on the shared decision making and the conversation that you're going to have.
Perfect, thanks. Hey, Dr. Best, are you available to precept?
Oh yeah, of course, sit down.
Great, thanks. I just saw my patient, Mr. Smith.
Mm-hmm.
He's well known to me, so for this follow-up visit that I think is pretty straightforward, I want to go with the step-up model.
Okay, sounds totally appropriate.
All right, so he's here for moderately severe COPD. He's had an increase in his dyspnea that I think is poorly controlled COPD. Briefly, he's a 64-year-old man, former heavy smoker, about 40 pack years, diagnosed with moderately severe COPD on his PFTs a while ago. His current symptoms are notable for dyspnea with 2 flights of steps and stopping after several blocks of flat ground in order to catch his breath. He's had a persistent cough, only productive of clear sputum though. Currently he's on LAMA monotherapy and he uses a short-acting beta agonist as needed. There's a decline in his functional status from when I saw him last 6 months ago. Thankfully, he hasn't had an exacerbation needing steroids or hospitalization. He has no signs or symptoms of heart failure. And otherwise, actually, his COPD care is up to date, including vaccinations. He's had flu and pneumonia, stable PFTs at today's visit, and a 6-minute walk test that didn't show him desaturating. He has a normal echo about 1.5 years ago, and I'm pretty sure that his worsening dyspnea is from COPD. So in addition to addressing that, my personal educational goals for this visit are to make sure I know the recommended timeline for the various screening tests in COPD patients. That being said, my plan for him is to escalate from a LAMA to LAMA-LABA therapy. And I want to talk with him about lung cancer screening since I think he meets the pack year requirement and he only quit 5 years ago. Also, I don't think I need a TT to evaluate for pulmonary hypertension based on his symptoms, but I've seen other people do that as a screening test and I wanted to see what you thought.
Okay, great. So based on what you said, it sounds like the plan for increasing the inhaler sounds totally correct and appropriate. And so the big focus for today's encounter is thinking about screening modalities, is
Yeah,
that
that's
right?
Mm-hmm.
Okay, so before we address that, let's just clarify a couple things. So you said that he's had a progressive decline in his symptoms over the past couple of months. You've thought about if this is just poorly controlled COPD, and it sounds like that's what you think is the most likely?
Yeah, I think that's what's going on.
Okay. And then you had talked about some of the other things that you considered, including volume overload, but that seemed unlikely. You had checked an oxygen already. So like I said, I totally agree with your plan to escalate his inhaler therapy.
Great.
Let's talk a little bit about screening options for COPD patients. So it totally sounds correct to do lung cancer screening with him based on the things that you had said. Do you feel comfortable doing this?
Yeah, I think so. I was going to use the CDC conversation guide. I've used it a couple times in the past, and it's been pretty good.
Okay, good. So I'll observe you in the room and see how that conversation goes. And I agree with you that probably screening for pulmonary hypertension is not recommended in this case. I know sometimes providers will reach for an echocardiogram, but I bet if he's still symptomatic despite the things you're doing, then you can look to get an echocardiogram to screen for that later on down the road.
Great. So then what we're going to do is we're going to go into the room. We'll confirm with him that he's had his pneumo vaccine and make sure that's documented in the chart. We'll escalate his pressors. We'll use the CDC conversation guide to talk about screening for lung cancer, and we'll go from there.
Sorry.
Escalate his inhalers, probably not his suppressors.
Ooh, I've been spending a lot of time making notes, sorry. Hey, Dr. Best, I'm running really behind. Do you mind if I just tell you about somebody really quickly?
Oh, yeah, go ahead.
Great. Mr. Smith's a patient of mine. I haven't seen him in about 6 months. He's got moderately severe COPD, a 40 pack year history. He's on LAMA monotherapy. He's having worsening symptoms. I think it's all just a stable COPD. I'm going to bump up his inhalers, but I also want to get a low dose screening CT for lung cancer.
Okay. Sounds totally appropriate. So increase the inhalers and low dose CT. Let's
Yeah.
go see him. And then what I'll do is, if I capture anything else in the chart or other things that we should have thought about, I'll reach out to you and we can talk about it.
Great. Thanks.